All right. Well, I think we should go ahead and get started. So welcome everyone. My name's Eric Walser. We're really excited and thank you for joining us for the inaugural Southwestern Ontario Critical Care Lecture Series. Anton.
Yeah, and I'm Anton Nicklin, another fellow at Western University.
Our hope with creating this series was to generate a content series that really showcases practical approaches to interesting topics for critical care providers throughout our region. We don't want to limit this to people who have specific training backgrounds or professions, but we really want to try and build a sense of community and collaboration throughout Southwestern Ontario. We have people doing really good, interesting work in a bunch of different places. But as trainees in London, we sometimes feel like it's not quite as coalesced as possible, and that's our goal.
Yeah, we want this series to last, and we are currently building our list of dates and topics for 2024. If you have any ideas or topics of interest, and especially if you want to participate, please let us know. I'll be putting an annotation for our email as well as the Google form for you guys to put in there. I also want to remind everyone that this is Section 1 mock credit that you can submit for through the portal.
We really would like to have participation from all sites moving forward. And in the new year, one of the things we're excited about is to try and create an interesting case series that showcases the diversity of challenges and different solutions that are present for different environments in the region. If anyone has a case they think would fit, it doesn't need to be a full hour. We're happy to do partial to split things up. We would be happy to chat about how to help do that and happy to help with some of the legwork of building out a slide deck and getting people interested to discuss it.
Now, to start off the first lecture for our Southwestern Critical Care series, we have Dr. Marat Slessarv. Dr. Slessarv is an intensivist at London Health Sciences, a clinician scientist in the Department of Medicine at Western University, and a researcher with Canadian Critical Care Trials Group. He is a regional medical lead for donation with Ontario Health, Trillium Gift of Life Network. His research is focused on innovation at the intersection of neurosciences, critical care, and organ donation, with multiple CIHR, NRFR, and Ontario-funded trials. He is a co-author on the recent Canadian consensus on brain death guidelines published in April. Thank you for joining us, Dr. Slessarv.
Thanks for that introduction. I'm super excited to be here, and I see some familiar names in the participants list. Hi, Anna. We trained together. I learned a lot from you, so it's good to it's a good walk through the memory lane to do this. So I just want to make sure you guys can see the screen. Yeah. Okay. Awesome. All right. So thanks for that introduction. So I'll get started here. These are my financial disclosures. As Anton mentioned, I do work as a regional medical lead for Ontario Health. So I do receive a stipend for that work. And I do hold multiple research grants for research related to organ donation, but none of this has influenced these guidelines. In terms of outline, we'll review why did we need an update to guidelines, and then we'll talk a little bit how was the guideline developed, and then we'll highlight some of the key changes in the current guideline. And I won't be able, and I won't have the time to go through all the changes and all of the little nuances, but I cherry-picked the top 10, I think that would be practically important and useful to the providers in Southwestern Ontario. And then I have a few cases that we can hopefully discuss together and use this newly acquired knowledge to tackle. So we'll start with the why. Why do we need to update our guidelines? Biomedical definition of death is important for a range of Canadian stakeholders, and there are excellent papers about this, but one that I really like was written by Sam Shami, where we acknowledge that death is a biological process. The body doesn't die all instantaneously. There are cells that take time to die, but we acknowledge that it is a biological process. But however, in that biological process, we need to define a specific time point where death is determined to have occurred. And this is a particular event in that process. And that is important for healthcare providers because we need to have physiologic criteria for death determination. We need to know how to assess those criteria. And this allows us to determine whether we are providing treatment to the patient, or in case of brain death, if the patient has been declared dead, it's simply somatic support that we are providing to preserve opportunity for donation. This definition is important for hospitals and healthcare facilities because they need to know who's dead, who's alive in order to triage their resources. For researchers, it's important to know who to offer research protection to and whether informed decision-making applies. And of course, it's important for patients' families because it is important to know when somebody has died to inform the grieving process, things like insurance and proceedings and estate settlement. So this is a very, very compressed and brief history of death determination. So prior to 1960s, prior to the invention of critical care units, death was defined simply as cessation of circulation and respiration. But advent of mechanical ventilators, of course, changed all of this. And ICUs around the world started to fill up with patients who would end up with severe brain injury that would render them comatose, and that coma would be irreversible. And so in 1968, an ad hoc committee of Harvard Medical School defines this term called irreversible coma or total loss of brain function, and advocates for that to be equivalent to the death of the person. In 1981, in the United States, the Uniform Death Determination Act is put forth, and that really defines this concept of neurologic death. However, this act acknowledges that neurologic death is a low incidence event, so it's not very common. It's less than 1% of all death, and therefore circulatory and respiratory standards should remain in the definition of death, and in part because that is more common, and also in part because it would be more acceptable from societal perspective to move from a concept of what everybody understood as death being a cessation of circulation and respiration to now also include neurologic death. However, that act of actually writing in legislature the fact that there is two types of death creates a lot of confusion. At the same time, in Canada, the Law Reform Commission of Canada is sort of debating of what should be implemented in Canada. And they actually proposed that a single unified brain-based definition for death determination, for death definition is proposed. And that should be written into law as a person is dead when an irreversible cessation of all that person's brain function has occurred. So this is a brain-centric proposal. And while it was supported by Canadian Medical Association and a host of other medical professional organizations, Parliament did not follow the LRCC's recommendation, although Manitoba legislature did. So because of that, in Canada, death definition is not written in law. And in most jurisdictions, it should be determined using accepted medical practice. And what that really means practically is that we should have guidelines on how to do that. And that's what prompted development of several guidelines. Most of them were done in 2006. You can see adult guidelines on brain death and donation after circulatory determination of death, as well as pediatric guidelines in 2017. Now, since that time, since 2006, advances in medical sciences, as well as ethical and legal challenges and ethical understanding of the various nuances, have created a situation where there was a need to update the guideline. And within the within the project of the guideline development, we had multiple subgroups, as I will tell you a bit about later. And in addition to the main document of the guideline, we also produced over 20 supporting manuscripts. And one of those manuscripts actually discusses the rationale for revisions to death definition and criteria for its determination in Canada. And this was authored by ethicists, lawyers, and policy experts. This is a very interesting paper. I invite all of you to read it in detail, but I picked out key rationale statements from this paper that I wanted to share with you. The first one, and I think the most important reason for an update, is that uniformity in death definition and determination is important for public and healthcare provider trust. And we already are seeing efforts internationally to formulate consensus statement with respect to brain death determination. And this is a screenshot of the World Brain Death Project publication in JAMA, where experts from around the world assemble to really look at the different formulation of brain death definition and sort of arrive at a consensus statement in order to provide uniformity. We also needed to minimize risk of diagnostic errors. And you can see that among the 20 plus publications, we had 5 rigorous systematic reviews and meta-analysis to really make sure that we review existing literature with respect to diagnostic accuracy of the various things that we do in death determination, including things like use of ancillary tests, as well as what is the arterial pulse pressure threshold for death determination by circulatory criteria. And the third reason, I think an important one, is we needed to account for evolution in donation and transplantation technologies. And one specific example that I wanted to highlight today is this method called normothermic regional perfusion, which is essentially a post-mortem donor intervention technique that is used in DCD donors after death determination, but prior to organ transplantation. And so the idea here is that somebody, when the donor is declared dead using circulatory criteria, they're taken to the operating room and they're put on a regional, what amounts to ECMO, which is basically a pump and an oxygenator that now circulates the blood either to the abdomen or to thoracoabdomen to reperfuse the organs with oxygen and reverse some of the ischemic injury that the organ sustained during the dying process. Now, in order to prevent blood circulating to the brain, the blood vessels that bring the blood to the brain are clamped or tied off, and that limits circulation of oxygenated blood inside the donor to either abdominal or thoracoabdominal organs. Now, there are lots of ethical and practical questions related to this, but the most important one is this one. Would restarting circulation in somebody who was just declared dead using circulatory criteria violate that death determination, right? So it's a bit of a circular argument. You just declared somebody dead because their circulation has stopped permanently, and 5 minutes later you restarted that circulation, albeit only regionally. So this new guideline enables NRP, and I'll clarify why it does so later on in the presentation. So the benefits of an updated guideline are numerous. They would clarify that all death is related to brain function. In doing so, they'll promote consistency in practice, minimize the risk of diagnostic errors, foster trust and integrity in the system, address a lot of legal and ethical challenges, and clarify acceptability of certain post-mortem intervention that are intended to optimize donation opportunity as well as preserve trust in organ donation. So this brings me to my second part of this talk, which is how was the guideline developed? Well, this was a Health Canada sponsored project, and it was Canadian Critical Care Society working together with Canadian Blood Services, Canadian Medical Association, and were the project partners in this. We had a steering committee that included international advisors, and essentially the whole group, the guideline group, was broken down into 7 subgroups, And you can see those at the very bottom of the slide there. I was part of the ancillary investigation group, but other members were part of the legal ethics group. And what's important here, you can see we had a stakeholder engagement group where donor families, so families of patients who were donors, were part of this important guideline development process, which represent actually a big shift from other previous guidelines. We had a representation from across Canada as well as international members joining our guideline group, and we had an equal split between male and female participants. The guideline was endorsed, and we had members participating in the guideline from all of these organizations. There's, I think, over 14 organizations that professional organizations in Canada that endorsed the guidelines. And we employed quite rigorous methods. We had two methodologists as part of this guideline, so Bram Rochwork and John Basmaji. And the way we tackled the guideline, the steering committee performed a scoping review and derived clinical questions that were then either answered by a PICO approach that some of you may be familiar with. This is an actionable patient intervention compared outcomes approach that is amenable to comprehensive methodology and grades evaluation, but also for the questions that would not be suitable for PICO approach, we issued good practice statements as well as foundational medical principles, which is a novel category reflecting stakeholders' collective subscription to principles that underpin frameworks for death determination in Canada. This was all done during the COVID pandemic, starting in 2020, 21, 22. And eventually resulted in the main guideline document, as well as 20 supporting manuscripts that all of them are listed on this website. There's a link below, and I have a little QR code that you folks can screen at the end of the talk. I encourage you all to bookmark this, and you can access it. I think it's all open access articles. So let's dive into it and review what are the changes from the previous guideline. Because the first one, and the most, I think, important one, is the new definition of death. Well, not new one, because as I mentioned, this was contemplated back in 1981, but this is finally now written into the guideline. So death is defined as the permanent cessation of brain function. And that permanent cessation of brain function is characterized by complete absence of any form of consciousness, which means that there is no awareness and no wakefulness, and absence of all brainstem reflexes, including the ability to breathe, which is something we test using an apnea test. This permanent cessation of brain function can result either as a result of a devastating brain injury, which is what's known as brain death, or due to cessation of blood circulation to the brain as a result of systemic circulatory arrest. So you can see we have one definition. Every death is defined as brain death, and leading to that could be either devastating injury to the brain or cessation of blood circulation to the brain as a result of systemic cessation of circulation, which is your form of circulatory death, so DCD pathway. So how do you explain this to the public? Well, CBS has produced this video, and I would like to show it to you, and you're welcome to use it when you try to explain it to families or other healthcare providers that work with you. This is freely accessible. Nope. Hold on. Guys, can you hear the sound or no? Okay, give me one sec. Shall fix that quickly by getting rid of my AirPods. All right. See if this works now.
The brain keeps us alive by acting as the command center of the human body. It lets us think, feel, move, breathe, and interact with the world. The brain needs to send signals to the lungs to breathe and collect oxygen. Blood carries oxygen to the whole body. Oxygen fuels all parts of the body and brain. Death occurs when brain function ends. There are 3 ways this can happen. First, the brain may have a serious injury and shut down. The injured brain may swell, so blood with oxygen cannot flow into the brain. Second, the heart may stop beating. If the heart doesn't pump blood to the brain, then the brain doesn't get oxygen. Third, the lungs may stop breathing. If the lungs don't collect oxygen, the heart stops beating. Then the heart cannot send blood with oxygen to the brain. In all 3 cases, the brain tissue dies without oxygen. This is permanent. Doctors can use machines to keep the heart and lungs working after death, but they cannot restart brain function. Because the brain keeps us alive, the end of brain function is death.
All right. So hopefully this is something that you folks can use in the future to explain or even to show to your trainees or to family health members. So the second big change is that because it's a new guideline, we have to make life complicated. So we decided to change the acronyms. So DNC is what was formerly known as NDD, and that stands for death determination by neurologic criteria. And DCD is now known as DCC, which is death determination by circulatory criteria. Don't ask me why, it's there. The third thing that's different is that in DNC, or neurologic determination of death, after cardiac arrest should be delayed by 48 hours unless there is imaging evidence of devastating brain injury compatible with death. And the rationale for this change is that the initial CT had post-ROS can be normal, and brainstem reflexes can return in the first 24 hours post-arrest. So the guideline group felt that the most conservative approach to this would be to have a 48-hour wait period before DNCs are attempted, unless there is evidence of devastating brain injury. And that's obviously open to interpretation, but I shall tell you that loss of gray-white matter differentiation is not sufficient to demonstrate devastating brain injury, because there are case reports of patients with loss of gray-white matter differentiation that would wake up and leave the hospital alive after cardiac arrest. So in patients with secondary cardiac arrest after primary brain injury, for example, somebody who had a large intracerebral hemorrhage, 24-hour wait period may be sufficient. But ultimately, I think what we need to demonstrate here post-cardiac arrest is that we allow enough time to assess neuroprognostication for these patients and demonstrate devastating brain injury compatible with brain death. Another big change is that now core temperature of 36 degrees or more is required for all ages to perform neurologic determination of death. And hypothermia, as many of you know, can cause depression of brain metabolism and function, and can alter pharmacokinetics of sedatives. And certain sedatives administered in the peri-arrest period or after patients admitted to intensive care unit can hang around longer in patients who are hypothermic. So the patients need to be 36 degrees or warmer to perform DNC. And in cases of pre-hospital hypothermia, so somebody's falling to a snowbank, the winter's coming, or has had induction of hypothermia, waiting for at least 24 hours after return to normothermia is advised. This is, I think, the biggest practical difference of the new guidelines. For those of you who remember, Canada and UK were the only 2 countries that ascribed to what was known as brainstem brain death. So in patients who had isolated brainstem injury, demonstrated irreversible loss of brainstem injury was sufficient to determine that patient meets the brain-based definition of death. That has changed, and as of the publication of new guidelines, Canada is now in what I call whole brain death camp. In other words, if the patient is presenting with isolated brainstem or infratentorial injury, we need to demonstrate absence of brain blood flow using approved ancillary tests. And the reason for this is as follows. So clinical tests that we use to assess brainstem function, including the apnea test, interrogate only brainstem function. They don't actually test cortical function. In isolated brainstem injury, you can have partial injury to the reticular activating system, that is the system that's responsible for wakefulness and consciousness. But that the injury can be sufficient to lose brainstem reflexes, but it may have not injured reticular activating system completely. And if you have preserved brain blood flow supratentorially, then the patient may still have degree of consciousness. Whether that's meaningful consciousness now, we can debate that at length, but it's sufficient to say that there is that potential. However, most isolated brainstem injury should progress to supratentorial brain injury by development of hydrocephalus or cerebral edema. However, the natural history of that process is unknown. So the recommendation is to perform serial exams over days demonstrating continued absence of brainstem reflexes, or ancillary tests to confirm cessation of blood flow to the brain. And the figures here illustrate that really well. So you can see that there is an isolated brainstem hemorrhage in this patient in the 3 CT images on the left. And but the supratentorial structures are fairly preserved. And when you do a CT perfusion on this patient, you can see that on this axial slide, there is absence, is darkness. There is no brain blood flow to the brainstem. However, there is residual blood flow to the cortical structures, and the same is seen on the nuclear medicine scan on the very right. So the recommendation is if you are going to declare somebody brain dead with an isolated brainstem injury, you need to confirm absence of supratentorial flow with a validated ancillary test. Now, this, if you want to read a little bit more about this rationale, this is one of the supporting manuscripts, and essentially, this is the figure that I pulled from the manuscript. The patient may appear that they meet brain death criteria because they have no motor responses and absent cranial nerve reflexes, but they may still preserved electrographic activity or supratentorial blood flow. Now, another change is the change in accepted ancillary tests. So let's start with what's out. Full vessel angiography is out. And the reason is we basically don't do that anymore in Canada, and there is very little data to actually confirm its diagnostic utility. The same goes for MRA. EEG is out because co-administration of sedatives such as benzodiazepines can result in suppression of EEG activity that would be in keeping with brain death, but you can still have preserved brain blood flow and function underneath those sedatives. And SSEPs and brainstem auditory evoked potentials are out because they didn't meet the diagnostic utility thresholds in the systematic reviews that we've completed. So what's in? So the nuclear scan remains in, as does the CT angiogram. And you can see that I put radionuclide perfusion scan at the top of this because it is associated with fewer false negatives. And this is because a lot of patients presenting with a brain injury will, in addition to a plain CT, receive CT angiogram. And there may be residual contrast hanging around in the head if there is slow flow states. And so sometimes when you do CTA, you'll see a whiff of contrast in the intracranial vessels. And it's very hard to interpret it if it's just stasis of contrast, so it's true residual. With nuclear scan, if the tissue is dead, there will be no uptake of radionuclides. So that's the preferred method. CT angiograms in, and 2 new methods in italics there are CT perfusion scan, and this is only available a few centers. There is a large randomized control trial called Index CT Perfusion that was completed. The paper should be coming out very, very soon. But based on the review of that evidence, it was determined that CT perfusion would meet the criteria for diagnostic utility. And you can see that formal transcranial Doppler is in. I should have underlined and bolded formal. This is not point-of-care ultrasound TCD. This is formal transcranial Doppler performed by trained neuro-ultrasonographer, interpreted by a neuroradiologist trained in neurosonography. Those, I think, are the two big changes of two new additional ancillary tests. So we also have more option for apnea testing. In addition to a regular passive oxygenation approach, positive airway pressure in patients who are susceptible to hypoxia due to recruitment is recommended. And that can be achieved using bag mask ventilator with a PEEP valve attached, or keeping the patient on the ventilator essentially in a CPAP mode or SIMV mode, and reducing the number of breaths to 1 or 2 a minute and allowing the CO2 to rise. You have to be careful when you're using this ventilator approach, because the moisture in the circuit and the cardiac oscillation can trigger the ventilator. And so the ventilator should be set in pressure support mode, as well as you as a provider should be aware of the potential of auto-triggering the vent. And what we've been using in London is exogenously administered CO2, as this allows both prevention of hypoxia due to recruitment, and it also speeds up completion of CO2 testing. One of our current fellows, Dr. Sean Cunningham, is completing an observational study about all of these different tests in Ontario, and hopefully we'll have some new data next year on this. The time of death. Well, the time of death is determined in circulatory criteria at the end of the 5-minute observation period, so no big surprises here. For DNC, it's at the end of the apnea test, if that's the last clinical test that you perform. Or if you order an ancillary test, that should say ancillary, not apnea, it's at the completion, not the reporting of the ancillary testing. Sometimes where you have two assessments, separate in time, either for pediatric patients or in case where two providers cannot be at the bedside for the completion of the clinical and apnea testing, completion of the first assessment is the official time of death, because the second assessment is purely a confirmation. So brain imaging should support the cause of devastating brain injury leading to DNC. And this is an obvious criteria. If you're going to declare somebody brain dead, you should have a cause that would be compatible with brain death. And for example, they had a cardiac arrest and they suffered an anoxic brain injury as a result of that. And this cause should be supported by imaging demonstrating devastating brain injury. And as I mentioned, that is fairly open to interpretation. And if you're not sure, I recommend that you reach out to your friendly donation support physicians to help with that interpretation. And the last, I think, change or clarification, I guess, is that circulatory arrest is defined as the arterial pulse pressure of less than 5 millimeters mercury or isoelectric ECG. So in donation after circulatory determination of death, we are supposed to use invasive arterial blood pressure monitoring. And when the pulse pressure is less than 5 millimeters mercury, that would be consistent with circulatory arrest. You say, why did you pick 5? Why not 0? Well, it's because of the error in measurement is plus or minus 5 millimeters mercury, essentially. So that's due to account for the error in the devices that measure arterial blood pressure. Isoelectric ECG can be used if invasive arterial blood pressure is not possible for technical reasons, or it's being refused by the SDM in pediatric neonatal cases, or it's being refused by potential donors who are undergoing donation after MAID. And this is where we most commonly see this. MAID patients who undergo MAID and are eligible donors prefer not to have invasive arterial line placement. And in those cases, we will use ECG leads to determine the best death has occurred. Now, you may recognize that for those of you who have been at the bedside for DCC cases or DCD cases, when we lose arterial blood pressure, when the pulse pressure becomes 0 or less than 5 millimeters mercury, it takes time for the ECG to become isoelectric because there may still be persistent PA activity without any circulation present. And that was recognized by the guideline panel, but it was felt that, especially in cases of MAID, the time difference between isoelectric ECG and the actual circulatory arrest of blood pressure is going to be very minimal. So the other thing is that auscultation and pulse palpation are not enough by themselves to confirm lack of circulation in donation. But they can be used to confirm circulatory arrest, determined using invasive arterial line monitoring. So that concludes sort of the 10 big changes to the guideline that I wanted to share with you today. And so I thought that we will next tackle some cases together. And so this is the first case. This is a 45-year-old male patient who was found intoxicated, what proved to be alcohol intoxication later on in the snowbank, and was brought to the emergency department. In the ambulance, he lost pulse, received 15 minutes of CPR. On arrival in the emergency department, he had another arrest with ROSC after 30 minutes. So total amount of CPR was 45 minutes. He's now in your ICU and has had no sedation, no response to motor responses to painful stimuli, and no brainstem reflexes. You come in the morning and the nurse is asking you whether you want to proceed with DNC or brain death determination today. What do you tell her? Right, you folks can unmute or maybe.
Yeah, if people want to answer, they can use the reaction button down low or the chat. And if we don't hear from anyone in the next minute, I'm happy to answer Dr. Slessarv.
All right.
Hey, Marat, it's Fahad here.
Hi, Fahad.
From St. Thomas, Elgin General. So I would tell the nurse that we'd have to wait for at least another 24 hours minimum. Couple of confounders here, alcoholic intoxication found in a snowbank. So I'm thinking he's hypothermic when he came in. Witnessed arrest in the EMS and the ER. So we would have to wait.
Yeah, I think, you have a couple of things here. So this is initial CT post-arrival, and essentially it's normal. On arrival, the patient's temperature was 29 degrees. The current temperature is just under 34 degrees. So the question is, do we want to go ahead with the NC? And I agree with you. I think, based on the current guidelines, in the absence of devastating brain injury, I think we should wait at least 48 hours, actually. And you've correctly identified the confounders, and there's hypothermia and definitely intoxication that can still be on board. So we essentially wait the required timeline. And so 3 days post-ROSC, you have the following CT at 48-hour mark, so which shows loss of gray-white matter differentiation, but more importantly, also shows sulcal effacement. You don't see nice foldings around the skull there. The brain has filled out all the space available. There's crowding of the ventricles, and you can see that this looks like a bad brain. Temperature 36.4. Fahad, do you want to go ahead with DNCs, and do you want to do an ancillary test in this case?
So compatible with the devastating brain injury. Now he's hypothermic. Sorry, he's not hypothermic any further. So at this point, we can proceed ahead with DNC.
Yeah, I agree. And I don't think you need an ancillary test in here because you have demonstrated progression of brain injury on imaging. You have allowed for that time. You have rewarmed the patient. You've confirmed that this was pure alcohol intoxication that should be out of his system now. So I think, yes, you can move ahead with the clinical exam. So the key takeaways from this case is that I think we should wait at least 48 hours after cardiac arrest, especially with normal imaging. Rewarm the patient to greater than 36 degrees. We waited at least 24 hours after achieving that temperature. Intoxication and lack of brainstem reflexes on arrival are concerning, especially in the context of synthetic opiates that are on the streets these days. They can be very long acting. So what may have been a little bit more reassuring in this case, if the patient presented to your ICU with brainstem reflexes preserved, say they had preserved pupillary reflexes and were triggering the ventilator, and then over time, despite not being on sedation, they lose those brainstem reflexes, that would have been reassuring about progression of neurologic injury, right? And you can see that last point is a plea to every provider in Southwestern Ontario to never use benzos for sedation unless the patient's in status epilepticus or something like that. We still see it from time to time. Patients are put on industrial doses of midazolam, and unfortunately, midazolam has a long context-specific half-life, and so in many cases, this delays your ability to proceed with clinical examination and requires an ancillary test, so creates basically more work. So if you don't have to, do not use benzos. Second case, 52-year-old female, hypertension, sudden collapse in the mall, EMS in the scene, no pulse, CPR with Roscoe for 10 minutes, initially reactive pupils and triggering the ventilator, but then loses all brainstem reflexes after arriving in the ICU. You have the CT there. And essentially, the question is, do you want to proceed with DNC? Is the ancillary test necessary? And if yes, which one would you choose? So we shouldn't pick on Fahad anymore because he's answered that. So I'm looking for other providers out there. Let's take this one on.
Hey, Dr. Slessarv, it's Logan. I can try.
All right, go for it, Logan.
So just looking at the scan here, it looks like there's some significant probably hemorrhage around the brainstem. So I'd be concerned about, like the sort of brainstem determination of death that you had talked about earlier. So I think you would definitely need some ancillary testing, like a CT perfusion scan to make sure there's no supratentorial flow. And you'd still probably want to wait at least like 24 to 48 hours before making that determination would be my sort of thoughts and working through it.
Yeah. So I think it's actually a very good point. I think two things. You recognize that this is an isolated brainstem injury because you can see there is bleed centered in the pons area here. The supratentorial structures as well as gray-white matter differentials are fairly preserved. We don't see evidence of massively elevated ICP or edema above the tentorium because you can still see the sulci there and the ventricles. Now, there is probably some hydrocephalus early developing here. And we know that if we give enough time here, that will lead to a cessation of supratentorial flow. So if this patient just arrived in your ICU and you would rush to do a CT perfusion scan, you may end up with the picture that we showed early in this talk where there is preserved supratentorial flow. So I agree with you, Logan. I think I would wait at least 24 hours, confirm that there is no return of brainstem reflexes, and that will probably take you to the situation of there is no brain blood flow. I would have probably picked a nuclear scan because, as I mentioned, CT perfusion is a very novel technique. We do it in London, but fairly novel. CTA, a lot of these patients with bleeds will have a CTA done when they initially present to characterize where the bleed is coming from. Aneurysm will not, but regardless, I think you're absolutely right. Ancillary test, and I would have just chosen a nuclear scan if we can. All right, so third case, 50. Oh, John.
Hey, Marat. Great presentation so far. I've discussed with trainees in the past, and I think this is just anecdotal based on my own personal experience about the nuclear medicine scan. So I thought it'd be a good time to bring it up. But I found anecdotally in our own practice locally that we're more likely to have a definitive like radiologic dictation from nuclear medicine scan that says like there is absence of blood flow compatible with neurologic death, or like the images provided are not compatible with neurologic death. Whereas sometimes with our CT angiography, there's like a sort of clinical correlation required, can't say with 100% certainty. So I usually advocate for the nuclear medicine scan as an ancillary test for that reason, but I want to make sure that this is sort of, I would say, evidence-based and not just me going off of my anecdata based on practice so far. So I was wondering if you could comment on that part.
Yeah, I think it's both. It's actually both evidence-based and practice-based. So a couple of things. You're absolutely right. So the way CTAs, there's different, actually, this disagreement on how CTAs should be read, right? There's different scoring systems. And suffice it to say, they go from simple, you look at like 3 or 4 or 5, 6 regions, to like 18, 24 region interpretation. And obviously not all centers have neuroradiologists reading these scans. And so not all hospitals have access to neuroradiologists interpreting these scans. And so I've seen a mix of interpretation, just like you say. Some would definitively say, I use this scoring, and according to this scoring, there is no evidence of intracranial blood flow compatible with the diagnosis of brain circulatory arrest. Right. Others have said, well, there is maybe some flow here, and there's a whiff of smoke in the M1 part of the smoke of contrast. I mean, in the M1 section of the left middle cerebral artery, and then you're like, okay, well, what do I do with this? Clinical interpretation required. So to that effect, we are working with the Neuroradiology Society and Radiology Society to develop a standard for reporting CTAs ordered specifically for determination of as an ancillary test. If you choose to order CTA because you don't have access to nuclear scan, I would advocate that in your order, you write specifically that you're asking for confirmation of intracranial circulatory arrest for brain death testing, essentially, right? So that sort of gives a little bit of specificity for the radiologist interpreting it. If the report comes in conclusive, you can ask for an overread from a neuroradiologist. But to avoid all of that, John, I wholeheartedly agree with you. Nuclear scan is the best way to proceed. And this was reflected in the systematic review and meta-analysis that we performed in the various ancillary tests, where nuclear medicine scan pretty much performed better at avoiding these inconclusive scans that you will see with CTA.
Thank you very much. That's very helpful.
Yeah. All right. So this is third case. I have just one more after this. 52-year-old male undergoing donation to made tomorrow. Nurse asks you what monitoring is preferred to confirm circulatory arrest in DCC after MAID, and how long should we wait after circulatory arrest for death determination? Who wants to take this one on? No takers. You don't have to be a MAID provider. You've heard the criteria, so you can take a stab, and it's a friendly discussion here.
Hey, Marat, it's Marc-Andre.
Go, Mark. Yeah.
So I think from your slide, you said for a DCC, an arterial line is preferred if the patient is agreeable to it. However, as it is the end of their life, they ultimately get to say, and EEG would be an acceptable alternative.
And how long should we wait, do you think?
Still 5 minutes?
Yep, 5 minutes. So, yeah, so the following day, you attempt to place arterial line 3 times. Not you, Marc-Andre, but some other provider. And they're not successful, at which point the patient refuses to have any more attempts. What's your alternative method?
EEG.
ECG, yeah. So isoelectric ECG. So just the key takeaways. We will use arterial line, pulse pressure less than 5 for 5 minutes to determine death has occurred. And the 5-minute period is there to ensure permanence of circulatory arrest. And there was a big study done called DPART. It's published in the New England Journal. You guys can read it. But essentially, it was an observational study to see what is the prevalence of what is known as autoresuscitation, which is basically circulation stops, we start the clock, and in what proportion of patients does circulation restart during the 5-minute observation period? And what is the longest time from the cessation of circulation to the time that it restarts? So the answer to the first question is about in 15% of patients, there will be transient resumption of circulation after initial arrest. And the longest time from the initial arrest to resumption of circulation was 4 minutes and 20 seconds. So the 5-minute waiting period is sufficient. So the last case is interesting. This is a 47-year-old female with ROS 45 minutes of the cardiac arrest. You complete DNC and the patient meets criteria. You sign the death certificate. You go to the family and tell them what the next step is to discontinue somatic support. They're shocked and tell you that they don't believe in DNC. What do they do next? Turn off the vent. Any takers here?
Hi, Marat. It's Anna. Nice to
Anna.
see you. Thanks for this great talk. I think, correct me if I'm wrong, there is certain perhaps cultures, and there's a precedent for this where people don't believe in this. So I think you have to tread very carefully, perhaps get ethics involved, and certainly don't turn off the life support at this present moment.
Yeah, you're absolutely right. So the reason I brought up this case is one of the supporting manuscripts in the 20 plus that I mentioned is this one on trust and conflict and death determination. And this is a reflection from the precedent case of Takesha McKitty. It was co-authored by Takesha's father, Stanley Stewart, Paula Chidwick, who was the ethicist at William Osler Hospital, where Takesha was, and Andrew Healy, who was one of the physicians caring for Takesha. And I thought if you're going to read one supporting manuscript from the 20 plus that were accompanying this guideline, I suggest you read this one, because this is not only applicable to, I think, donation cases, but in general to end-of-life care that we provide and the conversations that we have with our families. So there are a lot of takeaways in here, but one of the things that resonated with me when I was reading this is that first you have to acknowledge family concern and acknowledge the fact that different cultures, different people may have different reasons to not believe in what you're telling them. And the best way to proceed is to provide them with space, time, and to, first of all, to come to terms with the news that you've just delivered to them, and then seek their understanding, seek to understand what their source of is in mistrusting your diagnosis. What doesn't work is repeating medical and legal facts. The patient has been declared dead. In the province of Ontario, this is, brain death is death. Because doing so over and over again may inspire fear, doubt, and anger. But instead, we should be focusing on building trust, establishing common grounds that what we agree on, and really understanding family concerns. And definitely ethics consults are helpful. One of the comments from this article that resonated with me is that Andrew said that when the staff initially at William Osler's were quite distressed by this case and were asking, what are we doing here? What are we doing here? And we can all, I'm sure, relate to that experience. And initially he would answer, I don't know what we're doing here. But as the case progressed, he would say, we're caring for the people here. The people, meaning Takesha, the people meaning her family, right? So I think we need to sometimes zoom out from and detach from the the details of the case of our own feelings that we have and really think about it more holistically. So I want to end there. So in summary, I think we've reviewed the guidelines, and the big thing is that death is now defined as permanent cessation of brain function that can occur either due to cessation of blood circulation to the brain or direct brain injury. We clarified the criteria for death determination, new acronyms, please learn them. We reviewed some of the updated aspects of death determination, and I want to highlight that this is probably the most modern guideline in donation and death determination and the methodology employed. If you go to this QR code, you can scan it. It will take you to the website from CBS that has a guideline and the accompanying manuscripts all in one place. And you can just save it as a bookmark and access it at any time. And if you have any other questions, I'm happy to answer, and we're always available as a phone call consult to support your donation cases. Thank you.
Thank you so much, Marat. That was awesome. I'm happy to open it up to any questions. We have a couple, we'll go maybe a couple minutes over, but that was great.
It's Ross here at CCTC. Thanks again, Marat, for that excellent talk. I do have one question about ancillary testing in patients who have undergone decompressive craniectomy. Is there any recommendation from in the new updates on that? Thanks.
Thanks, Ross. It's a very important question. There is no caution is recommended in the new guidelines, but we are working on developing consensus statements in Ontario that includes neurosurgeons, neurocritical care centers, essentially, and neuroradiologists. Essentially, what happens, the intent of decompressive craniectomy is to save a life and to allow the brain to expand. And so the issue here is we, again, don't know the natural history of brain blood flow and the swelling of the brain with decompressive craniectomy. In the past, if decompressive craniectomy was done and brainstem reflexes were absent and the patient met DNC criteria, that would have been sufficient to declare somebody brain dead and move on. However, there was a case, unpublished case, in the United Kingdom where a young patient had decompressive craniectomy. They lost all brainstem reflexes. They were declared brain dead after, I think, 48 hours or 48 or 72 hours post-decompressive craniectomy, only then to have resumption of brainstem reflexes as they were being worked up for donation. I think it happened before the OR. And the patient eventually woke up and left the hospital with a very mild disability. So obviously that raised a lot of red flags. So the current recommendation is that following decompressive craniectomy, we wait up to 5 days, and you have a choice of either doing serial imaging and clinical examination to confirm absence of brainstem reflexes over the course of the 5 days, followed by full clinical exam. Or if you do perform a clinical exam, I think an ancillary test confirming irreversible cessation of brain blood flow is warranted. What I think we should be avoiding is performing a decompressive craniectomy and then 12 hours later trying to do a DNC, because I think that's it's hard to justify a therapeutic intervention that's intended to save life. And in the absence of good data on the natural history of this process to then move to DNC determination. So Ross, for now, it's wait, perform serial clinical exams, and then consider doing an ancillary test with the clinical exam. And I would just reach out to DSP for advice on that, donation support physician for advice. But we're working on the guidance document. All right, any other questions?
All right, well, I think that Marat would be happy to take any questions via email or X, or you can forward it, send an email to one of us, and we're happy to forward that on. I want to thank Marat for agreeing to be a part of our inaugural Southwestern Ontario Critical Care Series lecture. I hope you guys all really enjoyed this. we're committed to making this work in the future. We want to make it work for everyone. So send us an email at any of these emails, respond to the Google Forms. If you want to get involved, let us know. And we're going to put a preliminary or a plug in. We've confirmed our date for our next session, which will be December 7th at noon. Dr. John Landau, who's one of our intensivists and vascular surgeons, is going to talk about ECMO in Southwestern Ontario, the current state, who, when, why, and how to make it happen. And we're super excited for that. So thanks so much for everyone joining.
Thanks, guys, and thanks for organizing. This is really cool.
Yeah. Thanks everyone for joining.